Hi, I'm Dr. Pallavi Patri, Senior Consultant Nephrologist at Columbia Asia Hospital, Sarjapur.
I'm Dr. Manohar, Consultant Urologist and Renal Transplant Surgeon at Columbia Asia, Sarjapur.
So today we are sitting with you together to discuss a couple of questions that patients have put across to us. So we wanted to clarify a couple of queries. The first question that we received from patients is, what is chronic kidney disease? Chronic kidney disease is a condition that is where the kidneys are damaged. They are irreversibly damaged. They cannot recover, where the patient cannot recover kidney function. And so these are patients who often need to be monitored on an intermittent basis by their kidney specialist. Often chronic kidney disease is progressive, where the kidney function deteriorates quite a bit to the point to which patients require kidney replacement therapy. So the next question we had was, what is dialysis?
Dialysis and the types.
So dialysis is a form of kidney replacement therapy. So when a patient has progressed to a very advanced stage of chronic kidney disease, where the kidney function is insufficient to maintain several functions for the body, such as maintenance of electrolyte levels in the blood, maintenance of acid-base levels in the blood, maintenance of water status, the water level in the body, the patient needs to progress, needs to start on some form of dialysis or eventually go to kidney transplant, which we will speak about later. There are two forms of dialysis that are available to most patients. One form is called hemodialysis, which is a blood-based type of dialysis. The other dialysis is called peritoneal dialysis, which is non-blood-based. Hemodialysis requires the patient to come into a hospital setting or a dialysis center, where they have to be in the center for 4 hours connected to a dialysis machine. The dialysis machine removes blood from the patient's body. The blood is purified through a dialyzer. There's excess water taken out as well, and the blood is then returned to the patient's body. This process usually takes 4 hours, and as an outpatient, it's done as an outpatient basis, where, like I said, the patient usually comes in anywhere from 2 to 4 times, typically in a week, to a center. This type of dialysis requires the creation of vascular access, and Dr. Manohar can answer some questions about vascular access.
Yeah, so the vascular access is basically made a graft. A graft is either used, or it's a natural way we use the connection between an artery and a vein, so that there is an increased flow of blood from the artery into the vein. That is nothing but we are arterializing the veins, so that we get a good flow into the dialysis machine, so that the waste materials like creatinine, all those things, nitrogenous waste, are taken out in a higher flow where we have arterialized the vein. So we do it at few sites in the body. That is, one is radiocephalic fistula, which is done at the wrist. The next is the brachiocephalic fistula, that is at the elbow. Sometimes if these sites get failed, or if there are no good veins, then we do use of the grafts, which connects at the artery and a vein. So one more question they asked was like, how long this peritoneal dialysis happens and how it's done.
Right. So one form of dialysis, as we already discussed, is hemodialysis, which is the blood-based form. The other type of dialysis is called peritoneal dialysis. This type of dialysis does not require access to blood. This is a type of dialysis that actually the patient performs on their own or with the help of a caregiver at home. They don't have to come into a dialysis center. Peritoneal dialysis is, there's a procedure that needs to be done up front, where there is a tube that is placed in the belly, the abdomen of the patient. The tube just stays there as part of the patient's body. And there is a bag of solution, which is usually composed of sugar and electrolytes, that is infused into the abdomen through this tube. That fluid just stays in the abdomen for a period of several hours, and it's in contact with the blood vessels of the abdominal wall. It sucks out, the fluid sucks out toxins from the blood vessels and sucks out extra water from the blood vessels. Then that fluid is eventually drained again through the tube into another bag that's on the floor. So that one exchange is first removal of whatever fluid is in the abdomen from the prior exchange, and then reinfusion of fresh new fluid into the abdomen. What goes into the abdomen looks like clear water. What comes out actually looks like urine full of toxins and extra water. So a patient may infuse 2 liters fluid into the abdomen, and what comes out is maybe 2.2 liters, 2.4 liters, 2.6 liters. One exchange typically takes about 30 minutes. So drainage of waste fluid and input of fresh fluid, that whole process is called one exchange. It takes about 30 minutes. So typically a patient will do anywhere from 3 to 5 exchanges in a day. Occasionally a patient can get a machine called a cycler, where that is where the dialysis is done entirely at night. The patient hooks themselves up to the machine through the tube, and all the exchanges are done through the night, and they may not have to do any dialysis work during the day. This entire form of dialysis is called peritoneal dialysis. And again, Dr. Manohar can describe the procedure that is required to place the tube.
Yeah, in peritoneal dialysis, we need an access, for which what we do is Swanson catheter, what we use it. We pass it just below the belt line, so that even the catheter will not be seen outside. So it will be hidden under the cloth, that's too below the belt. So that catheter, we will place it into the intraperitoneal cavity. So there the peritoneal membrane, what the inside covering of the abdomen itself acts as a dialysis membrane, which helps in the peritoneal dialysis.
Okay. So both forms, we've had several questions about which form of dialysis is better. Actually, patients do just as well on either form of dialysis. The survival rates are quite similar for both. Patients who are on peritoneal dialysis may have a better quality of life. It's a gentler form of dialysis than hemodialysis, because it is a daily form of dialysis where there's a little bit of cleaning happening through the day, every single day. Hemodialysis, the patient tends to feel more fatigued after a dialysis session, because the dialysis is not happening every day. So there are intense sessions, 4-hour sessions done every other day or every several days. So there are differences in the two. There are some patients that cannot get peritoneal dialysis, for example. Those patients who have had a lot of surgeries in the abdomen may not have a good place to put the catheter, or may have difficulties with infusing fluid into the abdomen. So sometimes certain patients who've had a lot of surgeries in the abdomen cannot do peritoneal dialysis and may have to do hemodialysis. Some patients who have a very weak heart may not do so well on hemodialysis and may do better on a gentler form of dialysis, such as peritoneal dialysis. But on the whole, in terms of finances and the overall health of the patient, they're quite similar. Very often in India, peritoneal dialysis is not covered by insurance, so that may be a hindrance in terms of doing that process. But you can travel with either one, so they're relatively equivalent.
If we look into the dialysis or renal transplant, what do you consider which is more beneficial for a patient?
Right. So transplant is another form of kidney replacement therapy, and it is far superior for the overall health of the patient than dialysis alone. So if a patient is a good candidate for a kidney transplant, and we do evaluate the patient's candidacy for if they're healthy enough to undergo a transplant, they should undergo a kidney transplant. Dialysis, the average lifespan of a patient on dialysis alone, if they stayed on dialysis forever, is really cut short quite a bit. On average, most patients survive only 5 to 10 years on dialysis alone, whether it's peritoneal dialysis or hemodialysis. Whereas after a kidney transplant, the lifespan, quality of life, the health of the patient and the overall lifespan are increased substantially, and that's what all studies have shown, whether this is through a living donor or a deceased donor.
Yeah, one of the important things is that after transplant, renal transplant, the quality of life improves a lot. Like frequent visits to the hospital in case of dialysis, like once in 3 days, 3 times a week, we need to visit for hemodialysis. Sometimes peritoneal dialysis, we need to often visit the clinician to look into that what's going on. Some problems may arise with all these things, but I think so once the transplant is done, it's definitely quality of life improves much. And one more important thing is if you look into that monetary aspect also, what they say that if we look closely, a patient who can survive after about 5 years, that means he has definitely earned a lot, like compared to whatever he has to spend for hemodialysis or peritoneal dialysis. So one more question they had asked was for what do they have to take the medicines lifelong, and what are the types of medicines, like how many medicines? This is a lot of patients have the apprehension regarding this immunosuppressants.
Right. So kidney transplant is basically taking an organ, a kidney, from one person and putting it into another person. So the major issues that we deal with kidney transplant is the recipient, the person receiving the kidney transplant, the immune system. Because the kidney is coming from another individual, the person that is the recipient the recipient's body will try to fight that kidney because it is considered a foreign, something foreign to the body. So just like your immune system fights infections, the immune system would also try to fight this kidney. So the big battle that we have post-transplant is trying to manage the recipient's immune system so that they accept the kidney as part of their own body. This process requires giving the patient medications called immunosuppressants, medications that suppress the immune system. So as of course we try to suppress the immune system so the body can accept the kidney, we do also weaken the immune system against all other things as well. So the risk of infection goes up as well. So post-kidney transplant, the two things that we're always trying to balance is the risk of infection and the risk of rejection. Remember, despite all of this, the patients do still do a lot better than on dialysis. But that being said, transplant patients do have to be on medications lifelong. These are immunosuppressant medications to control the immune system lifelong. The risk soon after transplant with all of these medications, with both rejection of the kidney as well as infections, that risk is the highest immediately post-transplant for the first several months post-transplant. And then these risks, diminish somewhat down the line, although things can happen down the line. Complications can definitely happen down the line with kidney transplant.
Yeah, and one more question I've got here is who can donate a kidney? I think so I'll take this question. I think so any person who is above 18 and less than 70, who's healthy, like he's free of ailments like kidney diseases, heart diseases, cancer, or diabetes. So who's willing to donate his kidney to his sibling or to his known person can definitely donate his kidney to the needed. So the other question was like, how does cadaveric donation work or something? Again, the cadaveric donation, this is what you spoke previously was a live donation. Again, the cadaveric donation is the kidney where we get from a brain dead person. So once there will be a committee, once we approve that the patient has got brain dead and the kidneys are functioning well, and his creatinine at that time is up to the normal, so then we consider for the deceased donor donation, and that is once again we get the request from the relatives also claiming that the kidney can be donated of the cadaver. So such patient can donate the kidneys. So one more question we have.
One thing just to add to that is that in order to be listed for a deceased donor, patients in India already have to be on dialysis. So in Karnataka, you have to be on dialysis for at least a period of 1 month in order to be able to be listed for a cadaveric donor. And there is a wait time to be able to get a cadaveric donor. And that wait time to some extent depends on your blood group and so on. With a living donor, you don't have to be on dialysis. You can do what's called a preemptive transplant. So you can, if your kidney disease is advanced enough, the nephrologist and the surgeon can work together to time a living transplant. So a transplant that comes from a living person, even before you ever reach the point of dialysis.
A few questions may arise in a person who donates the kidney, like how long, what's the life expectancy of a patient, of a donor who has donated the kidney? What do you say about it?
So most patients who donate kidneys, who are fit enough to donate the kidneys are actually very, very healthy people. You can think of them as a very select population select group of people within the population. They are screened head to toe by us. We look at several aspects of their medical health, and only if we feel comfortable enough that they're going to be healthy enough to donate will we allow them to donate. So if you compare the donor to the general population, they do very well. Their life expectancy is better than the average person on the street. They're at very low risk of developing kidney disease themselves in their lifetime. If, however, you compare a kidney donor, someone who is fit enough to donate, with two people who are fit enough to donate, one of whom donates and the other one who does not donate, there is a slightly higher risk for the person that is donating the kidney in comparison to the person who does not donate at the same level of health. But that risk is so minuscule that we still think that it is overall, beneficial because it's such a huge benefit for the recipient. We still go ahead and go through with that donation.
Again, if Dr. Pallavi was speaking about the risk, so what are the risks? So if we really look into the risks are very, very minor, like the risk of developing a hernia at a very later date, or risk of developing any wound infection. And I think so. Other than that, they can develop the kidney disease, but again, there's a very rare, and the complication rate is very, very, very minimal. So in fact, we always tell the donor to take care of their healthy lifestyle. So in fact, indirectly, the donor will take care of himself so well. So if you look into the donor and the non-donor person, we can say that donor will live long in an indirect way by taking care of himself very well.
Donors do have to have follow-up every year. They do have to be careful with medications that they take, just like any other kidney patient would. But on the whole, as we've said, donors do very, very well.
Yeah, I think so. I think so we have almost clarified all the questions.
Yeah, I think there may not be any further questions. If anyone has any further questions, please feel free to ask us
or mail.
Or mail us. You can ask us through the Facebook site, or you can send us an email, and our email addresses will be listed on the Facebook site. Thank you very much.
Thank you.